Welcome everyone to our second live stream salon. And we're really glad that you can all join us tonight. And we're going to be talking about a topic. Well, I won't be talking about it, I'll be asking questions. But our guest will be talking with knowledge about a topic that concerns us all, which is the effects of the COVID epidemic. What it means and what the vaccines promise or don't promise. And so our guest tonight is Dr. Kheriaty, who is a professor of psychiatry at the UC Irvine School of Medicine. He's director of the medical ethics program at UCI Health. He is chairman of the medical ethics committees at UCI Hospital and at the I didn't know this, and at the California Department of State Hospitals. I better show you more respect. Anyway, I do respect, but more. Aaron is a graduate of Notre Dame, and he has an MD from Georgetown University, and he completed his residency training in psychiatry at UC Irvine under, I believe, Gerald McGuire.
Yeah, that's right.
Who is the founder of the School of Psychiatry, or the Department of Psychiatry at UC Riverside.
Correct.
Now, and is a wonderful human being. He's written several books and many articles on bioethics, social science, psychiatry, and religion. He's been published in all kinds of places: the Wall Street Journal, the Washington Post, Public Discourse, First Things, and he's been interviewed by the New York Times, the Los Angeles Times, CNN, Fox, NPR, all those guys, about medical ethics subjects. He has also been, and he'll tell us more about this, but he served as a consultant on COVID response, ventilator triage, early on, I believe all this was, and vaccine allocation to the UC Office of the President, the California Department of Public Health, which needs all the help it can get, and the Orange County Department of Health, which also, well, we all need all the help we can get. It's not anything you can single out people for. We all need help. So Aaron, tell me, how did you get involved? You're a psychiatrist, so how did you get involved in COVID response?
Yeah, I guess I was in the wrong place at the wrong time when the pandemic hit. As the director of medical ethics at Irvine, several folks reached out to me. I first put together a group to look at the issue of what happens if we run out of ventilators. And we were working on this.
Which is an ethical issue.
Which is an ethical issue. How do we allocate a finite number of ventilators if we exceed our surge capacity? More people that need ventilators than there are ventilators. How do we handle a situation like that? Very difficult situation, obviously. But in the early days of COVID, we were seeing in New York, or foreseeing the possibility that might happen.
Yeah.
Now, thanks be to God, that didn't happen and still hasn't happened. But we wanted to be prepared for a worst case scenario. So started working with a group that I put together at UCI, and then from there got involved at the UC Office of the President, which sort of oversees all 6 of our hospitals across the state. So we put together ventilator triage guidelines for all of the UCs.
So the University of California has 6 hospitals?
Yes, some in Northern, some in Southern California, if you count Riverside and San Diego and UCLA and UCSF and Davis, and I may be forgetting one.
Okay.
So yeah, pretty good representation of what's going on in California if you look at numbers at the University of California hospitals.
Right.
So those guidelines are publicly available. You can find them online. We're trying to be transparent about and upfront about if we reach this sort of worst case scenario, how will we make these decisions about who gets a ventilator and who doesn't? And the basic idea is save as many lives as possible while at the same time respecting everyone's inherent human dignity and human equality, trying not to exacerbate already existing healthcare disparities, things of that nature. From then, what happened was the state of California published similar guidelines and got some immediate pushback from groups looking at issues related to disability rights and the possibility of age-related discrimination.
Right.
And there were signals coming out also from the Department of Health and Human Services at the federal level their Office of Civil Rights was very keen on making sure that these guidelines didn't unfairly discriminate against the aged. Now we know COVID disproportionately impacts people over the age of 70. So, insofar as age is directly relevant to prognosis, it might be a factor. But we couldn't take age as a standalone factor. We had to look at what is the possibility that this person would have a good outcome versus a bad outcome when we're thinking about ventilator triage. And initially, the state's guidelines needed some, I guess I would say they needed some work. They recognized after they got some public feedback that we didn't hit the mark the first time around on these guidelines. And so they reached out to a couple of us on the UC committee. I think our guidelines were a good model of how to avoid those potential pitfalls, those problems. So I got involved with the state, consulting there. And then when this medication remdesivir came along, which hasn't proven to be terribly effective, it has some marginal benefit for people with COVID, but there was a short supply of that. So then there were questions about how do we allocate remdesivir? And then with vaccines on the horizon, starting several months ago, the possibility of a vaccine rollout, everyone knew that it's going to take time to ramp up production. We're not initially in the first months of vaccine production going to have enough for everyone who might want it or everyone who might benefit from it. And of course, there were ethical questions about safety and efficacy. Are the vaccines being rushed to market under the pressure of the pandemic or various political pressures in play?
And there were other possible treatments, weren't there? There was the one, dare I mention it, there was the one that Trump was touting. I forget the name of it.
There was hydroxychloroquine, which is an old generic medication. And there were antibody treatments that were being developed where you actually get infused antibodies that have been used in other diseases as well. And there was some evidence that they might be useful in COVID. So we were looking at some of those so-called monoclonal antibodies and the allocation of those. So all of these very limited resources, who gets them? How do you do that fairly? Those are hard questions. Those are
and
really
not to mention masks, because I believe you were a mask go-to guy.
Well, I was a sort of, in the early days, no one really knew what was going on. Truth be told, we were not well prepared for a massive pandemic, although we should have been. We had a warning shot across the bow in 2009 with previous scares that didn't turn out to be as bad as COVID.
Schwarzenegger had actually bought stuff that was no longer useful.
He built up he built up a huge stockpile in California of portable ventilators, personal protective equipment like masks, and then when the economic downturn hit after 2009 and the state's budget was crunched, people started wondering, is it worth spending $2 million a year to replace the batteries and to maintain stuff and to keep this thing going? And some geniuses in the state legislature decided, even though they had invested much more than that to build it up, that the maintenance costs were pretty minimal. They ended up literally selling this stuff on eBay. There was a good LA Times investigative report on this. So we didn't have the personal protective equipment that we needed. And so I started sourcing stuff from local construction companies, and my office became a clearinghouse for N95 respirators, hazmat suits, and all kinds of crazy stuff that people were donating. So I rolled up my sleeves and sort of dove into trying to help our institution with COVID. But then as the dust settled, I started doing more intensive work on big questions of policy, for California, for the County of Orange, and for the UC system or my particular hospital. So that's been I've been pretty knee deep in COVID all year long, wearing my medical ethics hat.
You also had COVID. You and your whole family had COVID, which I think you got at a monastery.
Anyway. I acquired COVID in the community. Fortunately did well, had about 2 days of symptoms and recovered very quickly. My wife and children got it. The kids had very, very mild symptoms, but the positive antibody test later showed that we had all been infected. And so I'm recovered from COVID, And with all due respect to those out there who have suffered enormously because of this virus this year, paradoxically for me, being someone that did well with the virus, I can say it's one of the best things that happened to me in 2020 because I worry a lot less about it being on the other end of it. Now, obviously, that's not true for the folks who haven't had it yet and are wondering, am I going to have a good outcome or am I going to have a rough go of it or a potentially bad outcome? But my own personal experience with COVID, as most people my age would attest as well, was that it was like a case of 48 hours of influenza.
Let me ask one more question about COVID, and then I want to switch to something else relative to COVID, but this is a more clinical or medical question. What do we know about those for whom it is most dangerous?
Right. So it's pretty clear now, and it's been clear for several months, who the people are that tend to have higher morbidity and mortality, hospitalizations, or unfortunately death. By far the biggest risk factor is age. Being over the age of 70, you have about a 96% chance of survival with COVID. Under the age of 70, that's like 99.9 something.
Wow.
So if you're under the age of 70, your outcomes with COVID, statistically speaking, are very good. If you're over the age of 70,
not so good.
Most people do fine, but obviously some folks don't. And as you age even more than that, those morbidity and mortality numbers go up. So 75 is worse than 70, 80 is worse than 75, so on and so forth. Now, there are some medical conditions that also put you at higher risk. The ones that have seemed to receive the most attention are being obese, having hypertension, or having diabetes, or some combination of those three conditions. There may be other more rare medical conditions that elevate your risk as well, but we have the most data on those because they're quite common in the general population.
Yeah.
And it's clear that those will elevate your risk somewhat, but even then, those medical conditions don't increase your risk as much as age increases your risk. So bad outcomes with COVID are mostly a function of age and secondarily a function of also having one or more of those co-occurring
What about the young people who have died?
Well, the young people who have died, and children have died of COVID, but the numbers are so small that it suggests one of two possibilities. And we don't know with certainty, so this is speculation. Right. One possibility is that these are kids that had something wrong with their immune system. So their immune system gets too revved up, perhaps in some cases, and they seem to get a chronic condition that can mimic other autoimmune disorders, or they're somehow immunocompromised. Their immune system doesn't function normally, and so they can't fight off the virus, and they have a bad outcome. But the fact is, in California, more children, and by children I mean more people under the age of 18, have died of influenza this year than have died of COVID.
Oh my. Oh my. That's a startling statistic.
It's startling, and I think it's surprising to many people, given the fact that we've closed down schools, and we can get to arguments about lockdowns, and clearly we didn't close schools primarily for the benefit of children, because as compared to influenza, they don't seem to be harmed by COVID.
Right.
And we don't close down schools for the flu
influenza,
season.
no.
Right?
We also have vaccines, but
we were worried about the possibility of children spreading it to people in the population who would be at risk. Okay, so I'm not saying that there are no arguments for this. I don't happen to find those arguments convincing, and we can get to that a little later. But the fact is, children themselves, again, unless you're an anomaly, your risk is not going to be any worse than it would be with getting the flu if you acquire COVID.
We're talking about young people, and we'll shift a little here. I know that Jonathan Haidt, who wrote The Righteous Mind, and then most recently The Coddling of the American Mind, I think it is.
Yeah.
with Greg Lukianoff, has said and has brought forward studies that have been done that show that the generation born after 1995, which is the first generation to ever have lived a life where they haven't had a cell phone,
right.
that the suicide rate among young men, that is under 18 and under, has shot up, and among young women in that age group, psychological disorders, bulimia, anorexia, depression, self-hurting, other things have skyrocketed. And so when you've got that backdrop,
yeah.
I'm trusting that data is correct. So enter COVID, and how has that affected that population?
Yeah,
and I know that you've written about the mental health effects of the pandemic and of the lockdown. So.
Right. Right. No, that's a great question. And it's true what Haidt has pointed out. Jean Twenge at the University of San Diego has also done a lot of work on this. She may have coined the term iGen to describe that generation.
She wrote a book, didn't she, called iGen?
Yeah. So, but she's looked at the mental health issues as well associated with the use of these electronic devices. And it's very clear that for adolescents and young adults prior to the pandemic, the iPhone came out in 2007, I believe it was, that we've seen rising numbers of various mental health problems as you've described. And even before that, starting in 1999, the CDC data on suicide has shown a rise in suicide from 1999 to 2018 in all age groups, with one exception. Those over the age of 75 had a slight decline in suicide rates.
Interesting.
After the year 2000. But everyone else, really since 1999, both men and women, have seen an increase in suicide in the United States, including suicide among 10 to 15-year-old girls has tripled.
Oh my gosh.
During this time. And this is another really striking thing.
10 to 15.
Yeah, it's very alarming.
Yeah, it is.
That we're starting to see more and more suicides in children right around puberty and even prepubescent children, which conventional wisdom was kids prior to puberty don't kill themselves.
Right.
That's not true anymore in the United States.
Wow.
That was true when I was in residency. It's not true anymore. Those numbers are, thanks be to God, still small, but those deaths are happening.
But the fact that they exist.
The fact that they exist is very alarming. Because we know you get a large rise with adolescence and with the physical and hormonal changes of puberty and the psychological and social challenges of that stage of life. But this is also occurring against the backdrop of suicide rates declining internationally during this period of time. So something is happening in the United States that's not happening elsewhere, which suggests to me that digital technology is probably playing some role, but it can't be the whole story. There has to be something else going on socially that would account for this. So we had a suicide crisis prior to COVID.
Right.
We had a crisis of what a couple of researchers at Princeton have dubbed deaths of despair. I wrote a piece about this called Dying of Despair in First Steps.
Yes.
Deaths of despair are deaths by suicide, alcohol-related illnesses, and drug overdose. And Case and Deaton, these Princeton researchers, one of whom won the Nobel Prize for some of his work, have shown that deaths of despair have been on the rise in the United States during this period as well. So all of us are probably familiar with the opioid crisis in the United States.
Yes.
So against this backdrop of rising rates of death by suicide, by drug overdose, especially the opioid crisis, and alcohol-related illnesses in the United States, then we have a pandemic, right?
Yes.
So what's happened since then?
Yeah.
This next part is not going to be the cheery, optimistic part of our conversation tonight.
We'll try to move to that.
Well, we don't know for sure regarding deaths of despair because it takes some time to get all of that data, but the early hints are not looking good. So let's talk about mental health during COVID. Actually, if we could, I have a couple of slides on this. I'm not going to inundate folks with data and with numbers, but just a few snapshots from a couple of data points can give you a basic impression of what we're dealing with. So the Gallup poll, which I think most of us are familiar with Gallup, nationally representative sampling, rigorous methods, started in the year, I believe it was 2001, started asking people just to self-report and self-describe their own assessment of their own mental health. And what you see here is that this year we got a 9-point drop in people saying that their mental health was, reasonably good.
Right.
And this is the lowest that number has been since we started collecting this data around the year 2000, 2001. So Americans believe that they're not doing as well in this regard. Next slide, please. The CDC came out with a study that was looking at numbers from, the study was published in June, but the actual data was from, I believe, March and April. And so this was more or less kind of the beginning of the lockdown period, the beginning of the COVID crisis. And 4 in 10 Americans during that month reported some clinically significant problem with their mental health, 40%. You see here that about a third of Americans, 30%, reported clinically significant symptoms either of an anxiety disorder or a depressive disorder. About a quarter of Americans early in the pandemic reported trauma and stress-related symptoms. This would be things like PTSD type symptoms that are impairing a person's functioning, not just like I'm stressed at work and it's bothering me a little bit, but no, this is actually getting in the way of me doing my daily activities. And this was specifically in relation to COVID, right? So not old war-related injuries or old other forms of trauma and stress, but specifically COVID-related trauma and stress. 13%, over 1 in 10 Americans reported that they had either started using or increased their use of drugs and alcohol, not just sort of recreationally or socially, but specifically to cope with the stress of COVID. So using these substances to self-medicate anxiety or stress. And most alarming to me, Roberta, is that during that month, in the past 30 days, 1 in 10 Americans had seriously contemplated suicide.
Yeah.
That's the 11% number that you see there. And even more alarming is in the age group of 18 to 24-year-olds. So young adults in the United States, college age, late high school, college age, young professional type folks.
The people who didn't get to graduate.
The people who didn't get to graduate. 24%, 1 in 4 had contemplated suicide, not at any point in their lifetime, but sometime in the last 30 days. That month. When that study was done in March. A quarter of young adults had considered suicide. Now, how many completed suicides do we have from that month? We don't know yet. It takes a year or two for the CDC to collect that data. Collecting data on suicide statistics is very difficult, and they actually tend to be underreported because if there's any ambiguity about the nature of the death, the coroner's less likely to code it as a suicide out of respect for the deceased or the sensitivity of the family. So,
dare I ask you about any case that you have known cases?
Sure. No, I'm glad that you asked this because this is, as you mentioned at the beginning, besides being a medical ethicist, I'm a psychiatrist. So the other hat I wear 50% of the time professionally is treating mental illness. But this is a very personal issue for me as well. One of the reasons I'm a psychiatrist is I lost a very dear friend to suicide when I was in medical school, and actually he was diagnosed when I was in medical school with manic depressive illness. In my intern year, he ended up taking his life. So I've been personally impacted by suicide. And just a couple of weeks ago, my wife and I lost a close friend, a young man, 17 years old, that I have known since he was an infant to suicide. He was struggling from depression, and suicide is obviously complex. Depression is obviously complex. Many different factors play into it. But I have no doubt that in this case, and in the case of the nephew of his next door neighbor, and a young 8th grader, 14 years old, who took his life just a couple of days prior, I think in both of those cases, the COVID lockdowns and the isolation from peers and the being at home from school contributed to the depression. I think it played a significant role. And so my worry is that there's a lot going on out there that for various reasons we're paying less attention to. And it's affecting not just people's ability to get through the day, but it's affecting mortality rates, right? These things are killing people, quite literally. Depression, trauma-related disorders, these things can be lethal in a sense.
Yeah.
Not only through suicide, but through other forms of reckless behavior, or people who are depressed tend not to attend to their medical health in ways that they should.
Well,
so
some people didn't get diagnoses. I know a staff member of ours had her father, I believe it was, wasn't able to get a cancer diagnosed in time.
That's right.
And by the time he did get a diagnosis, it was inoperable, incurable, and he died. So that's another factor. Also, I've read and I've also more heard than read, but I have read a little bit, that domestic abuse has increased in this period, which is a mental health issue as well.
We do know also that opioid-related deaths have increased during this period. 40 states, I believe it was in the month of June, had reported increases in opioid-related deaths. Some places reporting that their opioid-related deaths had doubled as compared to previous months or as compared to the same time last year. And I think it's helpful to do some comparisons too, to put some of these numbers in context, because I just tossed up some statistics here for us. But okay, well, how common are these sorts of disorders outside of the COVID pandemic? Well, the numbers for anxiety-related disorders have tripled from June of 2020 to June of from June of 2019 to June of 2020, right? So if you compare the same month this year to the same month last year, anxiety disorders were hovering around 8% of the general population, and then they went up to something like 26% of the general population. Depressive disorders had quadrupled. So baseline last year, June of 2019, about 6% of Americans were struggling with something like major depressive disorder or another form of clinically significant depression. And now that number is somewhere in the neighborhood of 24%.
Wow.
Okay, so these are very significant increases, right? Baseline suicidal ideation for 18 to 24-year-olds who, again, it was a quarter of them this year. Numbers on that are a little bit hard to come by for previous years, but they were definitely less than 10%.
Wow.
And possibly less than 5 or 6%. Okay, so we
have a mental health crisis.
We have a mental health crisis. We don't see these kinds of massive shifts from one year to the other in psychiatric epidemiology. This is not the sort of normal up and down variation that you can see with these types of problems and these types of disorders.
It's an aberration.
This is a huge aberration, right? It's an alarming aberration, and as we're deliberating the very, very difficult public policy questions, and I do want to emphasize when I comment on those, this is Aaron Kheriaty speaking with my own personal idiosyncratic opinions. I'm not representing
the
university or the county or the state or any of these other public policy folks that I might consult with. But my own view, my own personal view, is that if we're only looking at COVID case curves, or only looking at COVID mortality rates and trying to dial up or dial down our lockdown measures based on that, we're missing a huge part of the story. We are missing those people who aren't going to the hospital because they don't want to go to a hospital where they might get COVID. We're missing people who don't want to go out of their house because of lockdowns, and so they're not following up with routine screening for things like colon cancer and breast cancer. And so a lot of folks are predicting now that we're going to see a spike that's not going to show up right away, right? This will be in 5 years, 10 years, maybe even more, a spike in many of the cancers that we routinely screen for, or many of the other cardiac conditions, let's say, that we routinely screen for and catch early on, and therefore are much more able to treat. Many of those folks, if we miss and they go a year or two without that screening, the mammography or the pap smear or whatever it's going to be, the cancer may have advanced to a point where it's much less treatable. That's going to increase our morbidity and mortality from things like cancer and heart disease, which we know are the huge killers in the United States. So that's very concerning. One number that I ran across just the other day, so if you look not at older individuals, but at sort of young adults and middle adulthood, so 25 to 45-year-olds, we've seen a 26% increase in mortality, in death by any cause this year.
Oh my gosh.
As compared to last year.
Oh my gosh.
Right? And whereas
That's
only
stunning.
5% of the deaths this year in the United States are due to COVID, something
Is
suicide, drug overdose, missed diagnoses, medical issues that a person delayed going to the ER to get. We don't know what yet.
Right.
No one knows exactly what those causes of death were, but we do know that whatever's happening right now,
there's a huge increase.
there's a huge increase in younger individuals dying. Right? So again, everyone's paying attention to the COVID numbers, which we absolutely should. Right?
We just need to look at.
We just need to expand the scope of what we're looking at in order to make really prudential decisions and see, again, not only the mortality numbers from this year, but also some of the longer term, 5, 10, 15-year consequences of what we're doing today. And those are the conversations that as far as I can see, we're not having at the public policy level.
And if the, for lack of a better term, the iPhone generation, the I generation, was already experiencing increased psychological disorders and depression, what is the effect going forward, especially because in COVID, that's about the only way you can communicate with anyone.
That's right.
So we've been, I've spent more time on Zoom than and more time on my phone and more time on whatever, let alone anybody else. And children and kids are all going to school on Zoom. And I just was talking to someone today who has 3 kids under the age of 8, 2 of whom are in school. The youngest is not, she's 2 years old. But they've been, he was telling me today that their time with their friends is all on the screen. And we don't know the effect that that's going to have.
Well, we have some sense of the effect that that's going to have. Jean Twenge, who I mentioned before, has shown a pretty direct linear correlation between screen time for adolescents and poor mental health outcomes, like depression and anxiety. Now, what you're looking at on the screen can influence that, obviously. Chatting with friends over Zoom is better than flipping through the Instagram and comparing yourself unfavorably to all the other photoshopped people on there,
and
right?
being unfriended on Facebook.
Yeah, that's right. So I don't want to condemn technology here by any means. Zoom has been an enormous blessing that's allowed many people, including myself, to continue working. I can treat patients now via telemedicine that I wouldn't otherwise have been able to
I've been
treat.
going
we
to
can
doctors,
reduce their risk. So yes, all of that. 2.5 cheers for technology. But we have to recognize that when it's being deployed as the primary way in which we interact with one another, some very, very important and significant things are being lost. And I don't know that we yet fully understand the physical and mental health adverse effects of spending 6-8 hours a day on Zoom. I'm most concerned right now about children. about children who are trying to do school from home. And this is another thing I think, Roberta, it's very important for us to be aware of. The people who are making these decisions are not the class of people who are going to be primarily harmed by lockdowns.
Right. That's,
It's going to widen the gap between the haves and the have-nots. Let's just look at education, for example. Right? Doing school over Zoom, and I'll use my wife and I as an example. Our kids are at a terrific school, very small class size. They transitioned right away last academic year to Zoom during the early days of the pandemic. And we had our younger children doing
For those who
school
don't
from
know,
home.
you have 5 children.
We have 5 kids.
One in college,
and one in high school, and 3 K through
middle
8.
school, and down.
So just referring to the K through 8, because they were the ones who needed most help from mom and dad. That was a full-time job and more for my wife to be able to sit with them and walk them through. And that was with a heavily resourced school, with good ratios and everything you would want.
Well, this is also in a home where the father is a psychiatrist who teaches at a university hospital,
Right.
and a mother who has an advanced degree, who also is a music teacher and a performer. So
That's right.
This is not your average.
This is best case
Yes.
scenario of schooling at home.
Yes.
And it was bloody hard. And thanks be to God, our kids are back in person now at their school, and it's much better. But I can't imagine a public school kid who has 2 parents who have to work just to pay the bills, who's trying to navigate all of this on his own from home.
Yeah.
And the LA Unified School District, they're really embarrassed about this statistic, and they've blocked people from accessing the data since this statistic was released. But at the end of the previous academic year, on any given day, something like 30% of the students never logged in.
Oh my God.
To their classroom. Didn't finish their homework, or didn't complete the entire school day, or wandered off and had a snack while the teacher was talking, but didn't even log in. Right?
Whoa, that's damning.
So the educational
and now you
gap,
can't get the data for this year so far.
No. They're keeping a tight lid
yeah.
on how many kids are persevering through the Zoom school, Google Classroom
The
ordeal.
person I was describing before, who has the 3 kids under 8, it's his, fortunately, he makes enough money that he is the person, he's the sole money earner of the family. And his wife has had a full-time job because she's working with the 2 who are in, I think it's kindergarten and 2nd grade. Yeah. And then there's the 2-year-old who you just can't leave to her own devices. So she's like exhausted at the end of the day.
The kids with special needs.
Yeah.
We're getting in our psychiatry clinic, you have a Down syndrome child. Parents were able to manage the child at home, but the child had a day program that he would go to every day.
Which provided stimulation for him.
Stimulation, social interaction, stability and predictability.
Yep.
So kids who are developmentally delayed or have cognitive disabilities, their routines have been massively disrupted. And even well-resourced, fully invested parents are not able to manage the behavioral consequences at home. So they're stuck at home trying to help their child with special needs. It's a nightmare. I have not seen anything in the media about the plight of these children and these families, and what are they going to do when those activities that previously were available to them. So my worry about the school, Roberta, is I believe in the common good. I believe we all, should be contributing to lowering the risk of COVID for vulnerable individuals. All of us have a role in that. All of us have a stake in that. But there is a danger because kids are not harmed by COVID. And it's unclear still to what extent they are carriers or asymptomatic carriers of COVID to older individuals. There's debate about that. But for a theoretical and probably marginal benefit for the vulnerable individuals, We're closing down all the schools. We're closing down all the day programs. We're closing down soccer and basketball and the group sports and other extracurricular activities, and doing considerable harm to children. Very obvious harm that's clear to anyone who's working with them. Are we instrumentalizing children here? Are we using them as a means to another end where they're not really going to benefit? I think that's a moral concern that we need to be paying close attention to.
I've also read that even those who are able to go aren't able to keep up to the level they would have had they been in school.
Right.
So there's a learning loss as well.
Oh, for sure.
Well, we've talked about this too. I've heard you say that in the beginning you think the lockdown was the thing to do, but you have concerns, which you're already voicing, about that as the continued policy.
Yeah,
you want to speak to that?
So here's my view. Early on, when,
Nobody knew.
February, March, we didn't understand the virus. We didn't understand who was most at risk and who wasn't. We were seeing outbreaks and very bad situations in places like northern Italy. I think a hit the pause button for a couple of weeks until we figure out what is going on. The original flatten the curve meme, the idea there was slow the spread of the infection so that hospitals are not overwhelmed.
Yeah.
I'm sitting there working on ventilator triage policies. I'm a fan of flatten the curve.
Right.
I don't want to ever have to use this policy and actually deploy it. So I was supportive of that initially. But then, once we started getting a handle on how the virus was spreading, how people get sick from it, which people get most sick from it, how do you treat them in the hospitals?
Right.
What are the effective ways to approach ICU care for these folks? We started seeing the mortality numbers going up. Cases were rising, but that's because we were testing more people. So a lot of asymptomatic folks, or folks with a mild illness, were being counted as cases. Cases doesn't mean diseases. Cases means a positive test.
Right.
So someone who is not physically sick, doesn't have severe symptoms, but has a positive test would be counted as a case. So yes, case numbers are rising, and that's reason for concern. But mortality numbers were starting to improve. We flattened the curve. The hospitals were nowhere near getting overwhelmed in the state of California. When Governor Newsom decided to reinstate more severe stay-at-home orders after a period where things had been more open, I was looking at the data for the UCs. We were at 10 to 20% ventilator capacity. We were not approaching our surge capacity.
Wow.
Okay, so the rhetoric started changing around that time as well. We went from flatten the curve to stay at home in order to save lives.
Right.
Right? But implicit in that, which was at the time was never spoken, was we're going to stay at home until we get an effective vaccine.
Yeah.
Because staying at home does not eradicate the virus. It only slows the transmission of the virus, right? If we lock down for a year completely, 100%, nobody, which is impossible, obviously. As soon as we open up again, the virus is going to start spreading again. Right? So all you can do is sort of stretch out and slow down the new cases, right? But the only way to stop this pandemic is through something called herd immunity, which is a sufficient portion of the population becomes immune to the virus. How do you get that? One of two ways. Actually, one of three ways. A safe and effective vaccine that's distributed to enough people, or naturally acquired immunity by getting the infection and recovering from it, which is what
a lot of
most people do, right? 99+ percentage of people under the age of 70, that's the kind of immunity that they could acquire.
Being 71, this is very interesting to me.
And
yes, it's
or some combination of those. I would say a third thing is to do things that can strengthen people's natural immunity, and there are health-related interventions that can improve people's ability to fight off infections. So all of those things that we know we should be doing, and if we're locking down, we might be impairing people's ability to do a lot of those things effectively as well. So the secret hope, I think, after March was that we can lock down until we have a highly effective vaccine. That was an enormous gamble based on a kind of, I would say, axiological faith that science and technology could solve this problem. Now, in hindsight, we have a couple of vaccines that look like they may be helpful, and we can talk about
one was I've used the word released before, and you corrected me to say that they've Moderna. Pfizer is already being given to people in the UK and I believe in the United States,
yes.
The Pfizer vaccine. And then the Moderna one was I can't get the term right now. It's not released. It's made okay to use it in emergency situations or something. You explain.
Actually, both of them have the same status now as of today. Okay, so the FDA approves medications and vaccines through a 3-stage process that involves animal testing and then safety testing on humans, on healthy humans, to make sure that it's safe. And then efficacy testing on humans that is placebo-controlled, meaning you randomize people and half of them get the vaccine, half of them get a dummy injection of salt water.
Right.
And then you compare their outcomes to see if it's effective, if it does what you want it to do.
Right.
That last step, that stage 3 of the FDA approval process, is not yet complete for either the Pfizer or the Moderna vaccines. We're still gathering safety and efficacy data on those vaccines. So the people
taking it now are part of the testing data.
Well, yes. Now, that's not to say that we don't have any evidence that it's safe and effective. I want to make sure that I clarify. The FDA gave something called emergency use authorization to use those 2 vaccines.
Meaning all the indicators are so
Meaning
far.
we have some data so far. So far, the data looks good. In fact, the data looks quite good, better than folks expected. Okay, so that's good news.
It's good news.
Safety and efficacy for both of these in the early stages of testing look good. But I think in the interest of full transparency and honesty with the public, right, and folks are nervous about doing this because they don't, they're scared of the quote-unquote anti-vaxxers, or they want people to accept this. And I think a lot of folks are scared of Americans who think for themselves and do their own research and so forth, truth be told. So there hasn't been a strong emphasis on clarifying this point, but I think folks should understand that neither of these vaccines are fully FDA approved. They're still in phase 3 clinical trials. And so if you get the vaccine, it's being given at UCI. It's being offered to people like me, the frontline healthcare workers. This week, they started administering it.
Which one, Pfizer?
The Pfizer one, right? And we anticipate that Orange County will get a shipment of the Moderna one probably next week, so very, very soon. So both of those are being rolled out.
And describe to me how, you described how these vaccines are arrived at. As the usual idea I have as a total layperson is that, a vaccine is something where they kind of give you a low dose of whatever it is and then it immunizes you. So are these based on that theory or?
These both use a different technology. And it's a really fascinating and interesting technology, but it's not a new technology in the sense that it hasn't been tested for a while. It's been tested for about 10 years. Okay. But it hasn't been administered outside of testing situations. Okay, so it's novel in that sense. It's called, they're both what is known as an mRNA vaccine. Okay. And I'm not a vaccinologist. I'm not an infectious disease specialist. So this is a physician who doesn't have subspecialty expertise describing this. So take it with a grain of salt.
We were on your territory when we talked about mental health.
Mental health and bioethics, I probably can speak with more authority. But on this, basically what you're doing is in a vaccine like the ones any of us have received or that have been given publicly, you either get an attenuated form of the virus. You take the virus and you do something to deactivate or kill it, and then you administer it. And that triggers an immune response. from your immune system and lets your immune system get to know that pathogen so that when it encounters the live, real virus,
It goes full.
it's ready to go. It doesn't have to ramp up the production of antibodies using white blood cells called T cells and other white blood cells. So it gets you ready to more effectively fight off the virus. Or you take a little piece of the virus and inject it in the vaccine and sort of do the same thing. You trigger the body's response to the virus. This uses something called mRNA, which is basically something that tells our DNA what proteins to produce.
Oh, interesting.
Okay? Now, it doesn't change your DNA.
Right.
So this,
Don't worry
let's
about
do a
that.
little bit of myth busting.
Yeah.
It doesn't change your DNA. What it does is it tells your DNA to produce a protein that's found on the surface of the coronavirus. So your own body begins to express that protein, and your immune system then gets to know that protein. Okay, it's called a spike protein on the virus.
Interesting.
So this is a novel technology. We have
But
some
they've been
early
testing
data.
in controlled
In
environments
controlled
for 10
environments
years.
for 10
to see
years,
that
and
it's
animal models, and even, in human testing. There has been human testing of both
Okay.
of these vaccines. And they do trigger an immune response. That's clear because about half the people who got the Pfizer vaccine had a day or two of fever,
Yeah.
headache, other symptoms.
I had that with the
Right?
shingles vaccine.
So
So
now, the vaccine proponents are saying, well, that's a good thing. That's showing that the vaccine is working and it's preparing your body to fight off the real infection when it comes. And this mild response that you might get from the
Right.
vaccine is not going to land you in the hospital.
Right.
It's not going to kill you, and that certainly seems to be the case, all the indications so far in early testing. But there are some unknowns, right? It's unknown what the potential effects of this might be 10 years down the road. So anything long-term, we don't have good data on. We have short-term data of what happens immediately after you administer the vaccine, or maybe a couple of months after. These vaccines have also not yet been tested in children. They have not yet been tested in pregnant women. Although something like a dozen or so pregnant women found their way into the clinical trial because they didn't know they were pregnant when they got and then they found out a week or two later. And so far, it doesn't look like it harmed them or harmed their child in utero. Although, again, long term and how many of those women have delivered yet. So there are unknowns. There are certain populations where this has not yet been tested. And it hasn't been around and being widely used long enough for us to know a year down the road or 10 years down the road, are people developing problems? Maybe a higher incidence of autoimmune disorders is one thing that people have.
it's a question mark.
It's a theoretical question mark risk. I want to be clear on that. There's no evidence that these vaccines are going to cause autoimmune disorders, but there's a theoretical worry that you're triggering your own immune system to respond to something that's now being expressed by your own cells. A small, by definition, a quasi-autoimmune response. Well, I don't know. Is that going to have potential downstream effects? We don't know. Okay, so I understand all the reasons to push a potentially effective vaccine out early.
Huge.
Right? I think that's clear to everyone. If this is something that can
We all want
help
it.
us turn a corner and can help protect, especially those who are most vulnerable,
Yes.
let's not wait until we have all the T's crossed and I's dotted. If we have sufficient evidence, and this is a prudential judgment, how much evidence is enough? When do you green light something? Even the FDA approval threshold, you could argue, is arbitrary. You could always do more research. You could always do more studies. And some people think that these things should be released earlier. Some people who are more cautious think we need to wait longer. So all of that is subject to debate. But as the FDA defines approval, for public use, we're not quite there yet. So they're going to continue gathering safety and efficacy data on the people who are getting the vaccine in the early rollout as part of that phase 3 data. So I think it's important for folks to be sort of fully aware of the status of the vaccines, think through it themselves. I think it's a very personal decision. Get professional consultation, look at your own particular risks before you decide, whether you or not you want to get the vaccine. The early phases of the vaccine rollout do not involve children, but down the road, if we're following what the CDC is currently recommending, eventually the vaccine will be offered to children. Hopefully by that time we will have testing in children before it's offered to children. But for you and for your children that you might give parental consent for, I think you want to do, you want to think through this very carefully and assess your own potential risk and benefit with the vaccine, given the fact that it's so novel and it's not something we've been using for 10 or 20 years.
For those who are concerned about medications or vaccines that use materials from aborted. I'm a very pro-life person, so I don't like to use the word fetus because I think they're children. But I recognize that that's what people say.
Yeah.
So
thank you for bringing this issue up. I think this is an important issue for many people who are pro-life and who would be concerned about any medical technology, morally concerned, aside from safety and efficacy, about any medical technology where the development of that medical technology involved cooperating with abortion or using aborted fetal tissue.
And there are people also who are pro-abortion. They would call themselves pro-abortion rights. Who would object to? I mean, it's there's nuance everywhere.
Fetal tissue
who would
research.
object to fetal tissue research because to them that's inappropriate.
That's right. That's right. No,
So
thank you for making that point.
Yeah.
So there are lots of vaccines in the pipeline.
Yeah.
Okay. From
Like I've heard more than 100.
more than 100, but from major manufacturers.
Right.
I mean, the sort of front
People who do this.
runners, people who do this. There's maybe 8 or 10. Some of them have used fetal tissue to develop their vaccines. Pfizer and Moderna have not used fetal tissue or fetal cell lines to develop their vaccine. They have used fetal cell lines derived from fetal tissue to test their vaccine, but not to develop it. So there's some nuances and subtleties here.
Interesting.
So testing, is that an issue? Am I morally cooperating with something problematic by getting a vaccine that was not developed from but was tested using some of this fetal tissue? That's a difficult moral question, I think. And some people take a more stringent approach and say, I couldn't accept that for moral reasons. Others, including most of the Catholic bishops in the United States, have said, including the bishops of California, have said, no, there's not a moral issue with the Pfizer or the Moderna vaccine because neither of them was developed using fetal tissue. There's not going to be a risk that you're going to have small amounts of fetal tissue that make their way into the actual vaccine that you would be injecting into your body. And so that's the judgment that's been made by virtually all of the U.S. bishops, with a couple of exceptions. There are a few who have still expressed some moral reservation because of the issue of testing. Okay, so folks that are interested in getting more information on this, the Charlotte Lozier Institute has published helpful information. They're a sort of research think tank that looks at some bioethical issues and looks at issues that would be of concern to people that consider themselves pro-life. So that's a good information source to parse through that. And many of the bishops have published letters clarifying their position.
Where can people read the studies about the vaccine? Where's a good place to go for information about the vaccines?
Some of the information is not yet available because it's still being collected.
Yeah.
But the FDA has released some of the early data on both the Pfizer and the Mrna vaccine. So you can look at a good information source would be, you can find links on the CDC website, you could find links on the FDA website to information about the vaccines and the data that's been collected on them so far. I mean, some of this data is hard to interpret, right? And this, you can get down into the weeds on the statistics.
Yeah.
They can get rather confusing.
Yeah.
So, you know, not to.
It's early days.
It's early days. So.
I'm old enough. I've revealed my ancientness. To remember the polio epidemic.
Right.
And the miracle of the Salk vaccine.
Right.
And we all were I was in grade school, and we all got our shots. And one young person, a girl, 5 or 6 years younger than I am, got it. Mm-hmm. She survived, but she had issues. And I also remember I got a smallpox vaccination, which, as you can still see the mark on my arm. But my husband explained to me it was eradicated in 1979. So
which is a remarkable feat of public health.
Yes, it is.
And technology. And so thanks be to God that smallpox is gone forever.
Yes.
Right? That's hard to do.
That's like.
But it was done.
And may that happen to COVID someday.
But we also, as you pointed out from that one case, no medical intervention is without risks. There's nothing that's absolutely risk-free. Now, the benefits may outweigh the risks. They may outweigh the risks very considerably, but there's always some degree of risk, and sometimes the risk is individualized. Some individuals may have a higher risk of a side effect from a medication or a side effect from a vaccine. That's one of the reasons I think
this
is a very, very personal decision. Yeah. And I'm in favor of educating folks with honest, transparent, clear information about the risks and benefits and allowing people to make their own decisions. I think most people want to do the right thing for their own health, for their children's health, and honestly for the population too. I think there's a lot of folks out there that would look and say, I don't think I'm going to benefit from a vaccine, but it might benefit someone else if I get it. So I'm going to get it. I'm not
carrying it, and I'm not.
Right, exactly.
I'm not spreading it further.
Where I would draw the line is
that
coercion, right? I don't think people should be coerced, or even subtly coerced through, professional or travel opportunities for getting a vaccine, because I think that's.
I've heard you express concern about people would have to sign up for something, and if you haven't had the vaccine, you won't be able to do certain things.
Well, there's people in the tech world that are playing around with the idea of everyone downloads an app that will verify whether or not you've been vaccinated.
Well, you can find out if you're close to somebody right now who has had it.
That's different. That's social distancing information. But this would be something where basically you carry around some verifiable evidence that you have been vaccinated, which allows you to get on an airplane, or allows you to go into the store, or allows you to go to school or go to work. Most of these would probably not be enforced by the state or federal government. They probably would be enforced by private actors, like the corporation that you work for, or the airline, or the fill in the blank. Nonetheless, I think there's a worry there that you could be boxed out of travel and work and society and movement and access because you didn't get vaccinated, and perhaps you had a good reason not to get vaccinated. Perhaps you had reason to believe you would have a negative outcome from a vaccine. So those kinds of policies where things become coercive, that's where this begins to worry me. The other thing that I'll say in terms of in the we don't know category, there's two primary outcomes that we're looking at when we're testing these vaccines. One is, if you get the vaccine and then you get the virus, are you less likely to get really sick or to die?
Right.
So it's your own personal health outcome with the vaccine.
Right.
The other is, if you get the vaccine, are you less likely to acquire the virus and transmit it to someone else, even if you're asymptomatic or even if you get a mild case? Those are two different questions, right? It may turn out that the vaccine works for this, but not for that, or vice versa, or it may turn out that it's helpful for both.
Let us pray.
Right now, the data we have suggests that the vaccine reduces your risk of getting sick with COVID. We don't yet have data, and we may in the future, but we don't yet have data that it reduces your chances of transmitting it to others. So that's one of the things that researchers and investigators are still looking at, right? So if you get the vaccine for that reason, it may turn out that that works out, right? But it may turn out that the vaccine actually doesn't confer that benefit, or the benefit's only very marginal. We don't know yet. We should know more, hopefully, in a month or two on that question. But that's another one of the question marks about those two vaccines that are currently being made available to the public.
Let's one thing I know, the data I've read is that the 1918 Spanish flu that actually began in Kansas took the lives of 50 million people. And we're not remotely close to that. The last I saw was it was below 10 million worldwide. In fact, I think it was below 5 million, but I may be wrong about that now.
I think we're at 313,000 in the US, something like that. Don't quote me.
I remember when we passed 100,000. I was watching it every day for about 6 months, and lately I haven't watched it every day. But what I want to ask you on it, so that's a comparison, because I know, well, my whole family, my grandparents and my parents, but no, my mother didn't. But my father lived through 1918. He was a child. But his grandparents, they survived. Anyway, but what I wanted to ask you, maybe on a positive note, and then maybe I don't know if anybody's texted in any questions that they might want to ask Erin, or if there's just a few people here. Let me ask you this. Do you have anything to say to people about how they can prepare themselves, counter the potential negative mental health effects of the lockdowns, of the stress, of the questions about, do I take the vaccine or don't I take the vaccine, or which vaccine do I take, and do I go out at all? If I do, all those. We're back to your expertise.
Sure.
Do you have anything to say to people about how to respond in a way that's more likely to reduce the negative mental health effects?
Number one, stay connected with people. If you've recovered from COVID, or if you're in your own personal assessment of your risk is such that you're not concerned about meeting with people face to face and in small socially distanced gatherings, you're willing to take some more risks, that's great. But if you're concerned about COVID and you don't want to gather face to face with folks, do use this digital technology to try to stay in touch with other people. Make phone calls, use Zoom, stay connected. Another interesting and alarming finding of what's happened during the lockdowns, because we're really locking down the nursing homes for good reason, because those are the folks that are
most vulnerable.
Most vulnerable. That's where the outbreaks have occurred: nursing homes and prisons.
I have a friend who is 70 and has all the comorbidities, all three of them, and he's going nowhere. And my text to him is, "You stay home, but text me. Are you okay? Are you alive? What are you doing?" Anyway.
But even that's a two-edged sword. So, there's a fly in the ointment there. The Washington Post did an analysis of CDC data this year and found 13,000 excess deaths beyond what we would have expected from Alzheimer's disease.
Oh my goodness.
From people in these care homes.
Oh.
Now, what's going on? Why are people with Alzheimer's disease dying at higher rates this year? Probably has to do with social isolation.
Oh my goodness.
One of the known protective factors that slows the progression of Alzheimer's disease is social stimulation.
Oh my goodness.
Okay? So nobody's allowed to visit, so we're protecting you from COVID, great.
But you're gonna.
But you're declining faster from your dementia, and maybe you died sooner than you otherwise would have because you don't have that social stimulation. You don't have as much reason to get out of bed and be up and about and ambulatory.
So stay connected.
So stay connected. We know that social isolation increases mortality by about 30%.
Really?
In general, for the general population. Yeah, we're meant to be in community. That's how we're built.
Yeah.
What's one of the worst punishments that we can inflict on an individual? Solitary confinement.
Yep.
Right? It's you could argue it's a form of long drawn out torture. Many people begin to hallucinate under those circumstances. Their mind becomes disintegrated in a way because we're not built, you know,
Or social animals.
as it says in the good book. It's not good for man to be alone. I'll create someone to be with
I
him.
make a joke about that to my husband.
Yeah.
It's not good for man to be.
So stay connected. Introduce structure into your day, right? If you're working from home on Zoom, or if you're not working from home because you're unemployed, we didn't have time to talk about
that's a whole
unemployment.
other issue.
Unemployment increases mortality risk by 2/3, by 63%.
Oh my gosh. Well, we did a couple weeks ago. We did a live stream with Jim Palmer about homelessness, and he said that they're anticipating that when the breaks for rent and mortgage payments end, and people are expected to pay it all, that the people who work with the homeless are expecting a huge spike in people who no longer have a home because they can't meet that payment unless some other, something happens. So
we're already seeing problems with some families not being able to access food, right? There's more people going hungry right now, and the food.
I read that today. And
the food banks and so forth are overstrained. So there's that. So stay connected, maintain structure in your day, right? The stay up until 2 a.m, binge watching Netflix, sleep until noon, wear my pajamas all day, shuffle around the house, stare at a screen, not good for your mental health, right? So getting up at a fixed time, scheduling time for social interaction, scheduling time for some form of work, even if it's not professional work, but some form of work, home improvement type projects, perhaps, or other things that you can contribute to under the lockdowns. Embroidery, hobbies, what have you, but introduce and maintain structure in your day, setting aside time to be with other people, to engage in things that you find meaningful, and engage in some form of participation with a religious community if you are so inclined. We haven't talked about the beneficial effects on things like mental health and on suicide of prayer and participation in religious communities. But I've got a colleague and friend, his name is Tyler Vanderweel. He's in the School of Public Health at Harvard, and he's done some really interesting studies in the last couple of years looking at the protective effects on individuals in terms of lowering suicide risk of things like participation weekly in a church service or a religious community. And the effects are very robust and profound. And this is actually not new. We've known this for years, but Tyler's done probably the most large-scale, rigorous, kind of methodologically rigorous studies on this and shown some really interesting findings.
Have to talk to him.
You should bring him out for one of these salons. Now, he's running something called the Human Flourishing Program at Harvard. In fact, while I'm thinking of it, the Human Flourishing Program has put out some very useful, so they're doing high-level academic research, but they're also trying to reach out to the general public with advice and information on things that you can do to improve your well-being and your flourishing. So the Human Flourishing Program at Harvard, their website is another great resource for people to get some ideas about things that I can do under the law. They just published a very nice report specifically geared toward lockdown-related issues.
Wow.
So that's another thing.
Human Flourishing
Program at Harvard. But I'll mention one of his studies. This was a study of like 80,000 nurses in the United States, and those who attended a church service weekly were at 5 times lower risk of suicide than those who didn't. Those who went more than once a week, like daily mass or something like that, of the 80,000 people in that study, there were no suicides in that group of people.
Wow.
So very robust and remarkable findings.
Let's go to, there's some questions. And so I know there's some others because I saw a couple go by, but this one is, what do you know about ivermectin? I've heard that it is as effective as a vaccine.
Yeah. I don't know much, so I'm going to pass on that one because that's
not
my area.
Expertise.
Some of the novel treatments are not my area of expertise. There are
we
some.
We need the infectious disease person.
That's right. There are other things out there. Antibodies that you administer through IV, so-called monoclonal antibodies, have shown probably some clinical utility in treating people who are really sick with COVID. And there's other strategies that are in the kind of early stages of use.
Is there a place that people can go to get information about those things?
Well,
it's trustworthy. Yeah.
Trustworthy source of information.
Yeah.
The problem is it's changing all the time.
Okay.
And it depends on who you ask. And I mean, if I were to ask my infectious disease colleagues, some of them would be cheerleaders for monoclonal antibodies, and some of them would be skeptical. Some of them would say, yeah, hydroxychloroquine might help certain people. Some of them would dismiss it out of hand.
It's all in the we don't know enough
We're
yet
still
category.
in the we don't know enough yet about a lot of these therapeutics because rigorous studies take time.
Yeah.
And that's one thing that we haven't had a lot of with COVID. So we're scrambling to catch up.
Here's a question you can probably answer.
Yeah, thank you.
Any comment on the role of exercise to mitigate depression?
Yeah, and thank you for asking about this one because that was going to be another one of my recommendations. Exercise, right? If you can get outside and exercise, definitely get outside and exercise. If you need to stay in your home, find a way to do it in your home. Lots of research on exercise for depression. And for mild to moderate depression, exercise for 30 or 40 minutes, 4 days a week or more, has been shown to be as effective as antidepressant medications.
Wow.
Okay, if you do it consistently.
Wow.
Now, for more moderate to severe forms of depression, the effect is less robust. So your depression may get to a point where exercise alone or exercising good diet alone is not going to be enough. You may need psychotherapy, which can be done remotely now. Right. You may need medications.
Yeah.
So I don't want to present exercise as a panacea, but the evidence on exercise for depression is quite robust in terms of preventing relapse if you're prone to depression, and even helping you to recover more quickly if you've fallen into an episode of depression.
I know it got me through the total lockdown.
Yeah.
It was the only thing. And Howard and I walked all over. We mapped Corona del Mar. Could lockdown, isolation, depression, insanity become the basis for criminal defense?
Wow. I would not advise anyone, to take any risks in that regard, because I don't know how well that would go over.
Glad to hear it.
I mean, I'm not guilty by reason of insanity plea. But no, people are describing themselves as going insane with the lockdowns, and there's a reason for that, and that's that this is not normal.
Right.
This is, to my mind, the degree to which we've relied on this as a public health measure is not good. And we keep hearing that COVID and the COVID pandemic is unprecedented. COVID is not unprecedented. As you've pointed out, roughly every 100 years, we have a major plague. We have a pandemic. This one is nowhere near as bad as 1918 was, and it's nowhere near as bad as bubonic plague and the Black Death and things that we've seen historically elsewhere. So the COVID pandemic is not unprecedented. We've seen it before. The thing that's unprecedented is that never before in history have we quarantined the entire population. Never before in history have we chosen to quarantine healthy
Everybody.
people. Everybody. Right? That's what is unprecedented. My own view is that there's a reason that it's unprecedented. It's not because the people in the past were ignorant and stupid. They knew what to do insofar as they could to mitigate the effects of a pandemic. They knew about quarantine. They had some pretty sophisticated measures, even though they didn't have the germ theory of disease and all the nuts and bolts of how this worked. They knew that this.
In Venice, you went to an island for a month.
Yeah.
And you you brought stuff in, you sat at that place. If you didn't get sick, then you could go into the city during times of plague, which came and went a lot. And there's a podcast you can listen to on Religion Unplugged, if you look it up, with Kyle Harper, who was the provost at the University of Oklahoma. He's a professor at the University of Oklahoma. He's a classicist. But his book was The Fate of Rome, Climate Disease, and the End of an Empire. Yeah. And the book is about the role that epidemics had and climate together as factors in what happened to Rome. And his new book, which I haven't been in touch with him for a few months, I don't know, I think it's going to come out in 2021, is a history of pandemics. So that'll be, I'm looking forward to talking to him about that, because they've got a lot more data now than they had when William McNeill wrote his classic Plagues and Peoples in 1976. So this isn't new.
Our forebears were not stupid. No. And in fact, we may look back in 20 years and say, quarantining healthy people, on balance, when we looked at all the effects, both short-term and long-term, was not a good idea. My own personal opinion is I suspect we will look back and see many of our policies as misguided, counterproductive. The folks who have written the Great Barrington Declaration have advocated for more targeted lockdowns of vulnerable populations while allowing others more freedom of movement and to function.
There's the effect of the economy, which we sort of touched on. There's another question. In a season where even those whose mental health is, I keep ignoring you, I don't mean to.
We got to get back to Chris.
Yeah, we got to get to Chris. Whose mental health is okay, are utterly exhausted. How can we maintain better awareness of loved ones' mental health struggles as our own resources feel spent?
Sure.
It's a good question.
Well, I think that the first thing that I would say is that with your loved ones, you don't have to carry the burden of solving by yourself your family members' mental health difficulties. You can certainly help the people that are close to you and encourage them. But if you're feeling overwhelmed and thinking, well, how can I take on the burden of dealing with, my loved ones' difficulties with anxiety or depression, the first thing that I would say is, well, you don't have to do this alone, right? There's professional help available. Yeah. There are things that you and your loved one can do at home that can be helpful. So I would advise people, ignorance is not bliss in this regard. Ask how your kids are doing. Ask how your spouse is doing. Ask how your parents are doing. And try to create an atmosphere in which people feel free to speak about that. And the best way to do that is probably to disclose your own struggles in this regard. That I was doing pretty well before all of this, but now after several months, I'm finding that I get anxious when I go out to the store, or I'm feeling depressed and low and it's hard to get out of bed many mornings. So I'm just wondering how you're doing. By admitting your own challenges or vulnerabilities, you're giving permission for other people to also admit that I'm not doing too well, rather than, we all got to buck up and put on a good face and sort of put our heads down and keep plowing forward. That's not a great strategy once you reach a certain threshold. I mean, a can-do attitude is great, but we are bodily creatures who have inherent limitations, and willpower alone cannot push you through prolonged stress like the kind that we're dealing with now. So So open up some space to talk about it and just listen. You don't have to solve their problems. That's the other thing. Just begin by listening and affirming that, yeah, this is difficult, and I'm sorry to hear that you're struggling in that way. And
it's a recognition that part of what we're all in together is that.
That's right.
Is the stress and the kind of, I'm writing a book. I thought, okay, I should be able to get this finished. I could, and I've got a lot of ability to push myself, but it's not done.
Yeah.
And I'm hoping it'll get done in the first half of next year. But at a certain point, you can't push anymore. And then Howard started finding articles about, you feel like you're in a maze, you're in a malaise, you're not alone, and sending them to me, which it's kind of a relief,
Sure.
This is
the data I presented is, on the one hand, it's depressing, but maybe it's encouraging in the sense that, look, if you're struggling with this kind of stuff, you're obviously not alone. You're one of the 40-50% of Americans who is also dealing with this. So we're all in this together. We should probably go to
We've got a question up there that I want to get to, but you get to go first.
Mine's a corollary to that question.
Yeah.
So I was looking at your statistic earlier. So there was a report today in the news that the mental health provider community is completely overwhelmed. And a lot of studies done on this recently. My company's done a ton of surveys on it.
Yeah.
And people are finding telehealth is not the panacea that they think it is. Right, so to the point of your rising statistics and that question about what do you do with your loved ones, what do you, as advice to people who say, I want to find help, but I can't?
Sure.
Because help is not available, even though you would like
Yeah, I tried to make an appointment to see.
Let's repeat the question in case the people who are watching couldn't hear.
Yeah, so the question is the mental health system getting overwhelmed right now? Is it strained? The answer is yes, it's strained. And there are not enough providers to meet all of the demand. And certain people have better access to mental health resources than others. But with that said, there are some helpful resources out there. There are some low-cost resources out there that are available to many people that they may not know about. Many of those are local resources, so there's not one national clearinghouse that I can direct people to, unfortunately. In the state of California, I would recommend that people look up the California bishops last year published a pastoral letter called Hope and Healing on caring for individuals with mental illness. And if you go to the page where that's published and you scroll to the bottom, each of the Catholic dioceses, which are sort of like counties or regions in California, has a link to local mental health resources there. So that's actually the best sort of centralized clearinghouse that I have found to direct people to in California.
Well,
so
God bless the Catholic bishops.
Yeah, so they're, occasionally they're good for something.
Yes.
So that's one place that Californians can go to look for what might be available to help me if I'm uninsured or underinsured, or if I called some people on my insurance provider list and they're booked out for 3 months. But be dogged and be persistent. And many of if you live in an area that has a university with trainees, going to see a trainee, oftentimes you'll get very high quality care because they're being supervised by an attending physician. So I can put in a plug for our UCI clinic here. We're busy, but you can call and get an appointment with us if you're in Orange County to be seen.
And that's probably true of all the UCs?
Certainly by all the UCs in Stanford and the other places that have psychiatry training programs.
Probably USC.
In California, USC. There are quite a few psychiatry residency programs. So going to see a senior resident physician under the supervision of an attending, if you have to pay out of pocket, that'll usually cost you about half what you would pay in the community. And oftentimes they accept insurance. We accept most major insurance, whereas a lot of folks in private practice do cash pay only. So that's a good resource as well. So yes, mental health care providers are busy. We're busier this year than we were last year. A lot of it is going to be provided by telehealth, which is not as good as being seen in person. But we shouldn't let the best become the enemy of the good. right? Something is better than nothing. Certainly a telehealth visit is better than no visit at all. So avail yourself of those resources. Get a consultation if you're not sure, you know, if you have something that might require more assistance than just general health measures that you can take at home. It doesn't mean you're going to be in psychotherapy every week for the rest of the year. Maybe you just need a few visits to get some things in order, or to be directed to some cognitive therapy or behavioral therapy workbooks and programs that you can do on your own. So there actually is quite a bit available. And if you're able to get at least one consultation with a psychiatrist or with a psychologist to get an assessment and some recommendations, that's worth the investment if you're struggling in this area.
The question that's on the screen is, could there be an upside that this time has provided extra time for sleep, art, and other creative output, and it's been beneficial to some mental health? I have one anecdote in that regard. Is early on I did an article, it was in March or April it came out, about I was doing, part of my personal therapy for my entire life almost, since I was like in middle school, has been, well, when I was very young, my grandmother handed me a crochet needle and said, you're going to learn to crochet because you're going to be nervous in your life and you need to have something to do with your hands. So I used to crochet, but now I embroider, and I watch murder mysteries. Okay, you know, it's nothing like a good murder. Anyway, I'm a big fan of murder mysteries. So and most of the ones I love are British. But I watched these two American shows, and one is one of our family's favorites, which was Monk. Yeah. Because, well, we have a family that has Tourette's syndrome and OCD, and you know, we laughed a lot, and then sometimes they didn't see what was funny, but that's another issue. But so I watched that, and I watched another one because it was a show that I had heard a lot about, which was House. And what stunned me was the similarities and the differences in the outlook and the outcome. And I wrote an article about it. Well, a friend of ours, who I would not have expected at all, he's a professor, teaches political science, you know, whatever. He and his wife liked what they read about Monk, and they've watched all of Monk twice now. Yeah. And I get emails from them telling me how thankful they are because it cheered them up in COVID.
Sure.
So, I mean, what can I tell you, you know?
Yeah. I mean, there's
Monk.
there's no doubt, especially for people who economically could weather the storm, or who could work from home, that, you know, for many folks, I think especially early on in the pandemic, before it stretched on for too long, certainly a lot of folks, this was an opportunity for them to reassess my priorities and remember what's more important and connect more with my family. Our friend Brad Wilcox at University of Virginia, sociologist, his Institute for Family Studies recently saw something, and they were looking at both the positive and the negative outcomes of some of what has happened. And I don't remember the exact statistic, but the gist of one of the upsides was that children were reporting in general, you know, statistically, there's exceptions to this obviously, but there was a trend toward children reporting better relationships with their fathers.
Wow.
Because dads were working from home more, or if dads, you know, working a lot less or not working at all, that's not a good thing for him. But it's an opportunity for him to spend more time with his children, right? So this is maybe a good note to end on.
Yes.
I don't want to say that, I think it's certainly possible that we can see this only as a crisis. And I think we shouldn't take that view of COVID. We should try to see it certainly as an enormous challenge, but also a potential opportunity. And ask about, okay, well, if I am stuck at home more and I can't go to my favorite restaurants, or I can't get together in large crowds, I love big parties or whatever, okay, but maybe this is an opportunity for me to focus on some other things closer to home and get caught up on some projects that have been on the back burner, or connect and reconnect with people that I haven't been in touch with for a while, or strengthen my connection with those closest to me, because we're stuck under the same roof together. So I think
That is-
that kind of creative thinking is really important because we've talked a lot about vulnerability, but another concept that's important to remember is resilience. How do we build up our resilience? And we do that together, and we do that by engaging our strengths and talents, some of which may not be tapped in our professional environment. You know, maybe they're tapped when we have a little more free time, and those kinds of projects.
I was talking with a family last night who they had been able to spend time with their children that they hadn't been able to before, and it was very positive. And another one who found time to journal and really work through some things and spend, it was a spiritual meditative time. This is a person was a Christian, and reading the prayers of John Bailey and some other things, and journaling and thinking, and it had been really a positive thing. So yeah, you have a final word, I think. That's kind of a good question.
Yeah, let's wrap
end
up
with
this one. Okay.
And you can turn it to positive, Aaron.
Sure.
I leave that up to you.
Mental health effects of this widespread cultivation of fear, they're toxic. I'm really worried about this, actually.
It's good question.
I'm worried about...
I've been thinking about it, too.
I'm worried about the way a lot of this has been presented in the media, that an alarmist approach to COVID or a one-sided approach to this and our response to this has exacerbated a lot of fear and terror in people. And I mentioned on social media a couple of months ago, and this ended up, Rod Dreher, who you've had out here, picked it up on his blog. But I've literally had otherwise healthy people, or people with run-of-the-mill depression, anxiety. I'm not talking about people that have psychosis or paranoid thinking, but people coming into our clinic literally believing that the apocalypse is here. I mean, there's an apocalyptic kind of, the world is coming to an end. And I think that's diminished a bit since the election. I mean, leading up to the election.
This year has been a perfect storm.
It's been a perfect storm.
COVID, George Floyd, the election. Yes.
But enormous levels of fear. And we're conditioning ourselves to fear not only a hidden virus, but other people who may be a carrier of the hidden virus, right? So when I see someone walking down the street and maybe their mask slipped off their nose or whatever, and I take a wide berth, okay, that might make sense to reduce the risk of transmitting a virus, but it also unconsciously conditions my mind to see other people as threatening, right? So there's two basic ways that our emotional brain reacts to other people. I mean, just to simplify our emotional life down to the bare bones, there's an approach and there's a withdraw. And each of the various emotions and all the subtleties that have one of those two basic characters. And fear is obviously inclines us to withdraw from others. And for a species that's built, that's hardwired to connect and to be in relation and is only healthy and can only flourish when we're connected with others. And that's true even of introverts. We are, for months on end, conditioning ourselves to see other people as a potential threat. I don't know what the effects of that are going to be, but I suspect they're not going to be entirely positive. So I think, I don't know how to wrap that one up, but find ways to stay connected. I think people have to gauge what they're comfortable with and what they feel safe with, but don't let distancing from people or staying home prevent you from connecting with others. There are ways to do it. Schedule it, build it in, make a point of it every day. The only way that we can get through this is to do it together.
And thank you.
Amen to that.
Amen. The Christian message is that there's a God in this life is part of a longer life. And that, I think, is a sustainer that our society doesn't have, and which may speak to your friend's research at Harvard about the efficacy of spiritual communities. But I think your message, we're hardwired to be in contact. And so we need to stay connected and remember that we're in this together in a whole lot of ways.
Yeah.
And Aaron, thank you. One of the things I love about you is you always get solid information. And I'm really thankful for that.
Thanks, Roberta.
And thanks for the time. And thank you all, whoever's been watching, and thank you for your questions. And in January, on the 10th, we will have, God knows only in what form, we'll have Robert Alter, who is a scholar of religion and Hebrew, and has recently finished a new translation of the Hebrew Bible, and he's going to talk about, his last book was The Minor Prophets, and he's also written a book about translating. And so that'll be a different topic, and
Stay tuned for Robert
be fun.
Alter.
Stay tuned for
Terrific.
Robert Alter. Thank you all very much. Great.